Hi, everyone. My name is Osman Ahmed. I'm an interventional radiologist at the University of Chicago. And today I have the pleasure of presenting to you all about updates in interventional radiology and or interventional oncology. And the reason I say interventional oncology is because interventional radiology is a subspecialty of radiology. But even within radiology or interventional radiology, we have a lot of people who really focus on oncology or treating patients with cancer, and that's known as interventional oncology, and that's known as minimally invasive image methods to treat cancer specifically. And we really target the tumor directly to minimize collateral damage. It's not surgery, so some of the advantages of the minimally invasive procedures we do include quicker recovery and a shorter length of hospital stay. And the procedures that we perform are really boiled down into two major categories. One are called intra-arterial procedures, where we actually go through blood vessels and we kill tumors through those blood vessels. And the other type of procedure is known as percutaneous procedures, where we actually just take needles and guide them directly outside the body through the skin directly into the tumor to destroy the tissue using either heat or freezing based methods. So, where interventional oncology and neuroendocrine cancer or NET really sort of intervene is primarily in the liver, because NET patients often have metastatic disease to the liver, and that's really one of the primary places where cancer will spread in patients with NET. And fortunately for interventional radiologists or interventional oncologists, the liver is an organ that can really be treated by both of these intra-arterial or percutaneous treatments that we have. So, when we talk about these transarterial or intra-arterial procedures, what we're trying to do is we're actually doing a procedure called embolization, where we're actually shutting the tumor blood supply down. And the reason we can do that is because the liver has a very unique blood supply. It gets blood from two different sources. One is from the portal vein. That's about three-fourths of the normal liver gets its blood supply from the portal vein. And about one quarter of it, the blood supply comes from the hepatic artery, which is an artery. However, tumors that grow actually get it's actually reversed, where almost all the blood supply from a tumor in the liver is actually from the hepatic artery as opposed to the vein. So if we can go in and shut the blood vessels down to the liver, then we actually can kill the tumor without really effectively damaging the normal liver that much. And so this is what this looks like. The arteries are kind of like branches of a tree, and we go into the branch that feeds the tumor. And once we get catheter or a tiny tube there, it's known as a catheter, we can inject a myriad of things. And depending on what we inject, that's what the procedure is known as. And we'll sort of highlight that here. So here's a sort of a cartoon schematic of the liver. And there's a big tumor there, like kind of a ball, and you can see the branches of the artery look like the branches of a tree, and you can see there's specific trunks or branches feeding that tumor. This is what this actually looks like on a CT scan. This is a reformatted image. You can actually see the tumor. You can see the branches that feed the tumor, and then you can see branches that go away from the tumor. So what we do is what's called an angiogram, where we take a tube or catheter directly into the liver, and you can see here, this is what that looks like now. An angiogram where we're looking under live x-ray to visualize the branches. And this yellow arrow indicates that we are going to take a small tube, a microcatheter, all the way up into the branch that feeds that tumor. And then this is what, and again, on a sort of a cartoon level, this is what this looks like. Now that we're here, we can inject different types of things. So if we inject chemotherapy, that's called chemoembolization. If we inject radiation beads, that's called radioembolization. And most frequently with NET patients, we inject something called just bland beads or grains of particles, known as bland embolization. And as I mentioned, this is known as bland embolization. And the reason we like doing bland embolization with NET patients is because we really get what's called an ischemic effect, meaning we can actually, because the tumors in NET get a lot of blood supply, if we can shut all these blood vessels down, we can use really, really small particle beads. These are 40 microns. So we're talking, at a very, very small level. We can really cause what we call ischemia or necrosis, or basically tissue death of those tumors. So what does that look like? Here's an example. Here's a patient who has greater than 80% of their liver replaced by tumor. And you can see there all those basically white, bright objects in the liver there. And fortunately, what's interesting about the liver is that it's a very resilient organ. So the liver is actually only needs a very small amount to sort of do well. But because the liver is functioning normally, no matter how much tumor a patient has, we can go in and do these intra-arterial type procedures. So this patient, this is what the angiogram looks like. You can see here, I've sort of outlined here all those little light bulbs that I showed. That's what it looks like on the angiogram. And then this is what it looks like afterwards. We inject a bunch of beads, and you can see here now all the blush, all that dense tumor blush staining is gone. And so that's what we're aiming to do. We're trying to preserve the blood flow to the liver, but we're trying to take out all the blood supply to those tumors. And this is the follow-up. This is what this looks like. You see less tumors, and you don't see that they're enhancing anymore. So that's compatible with dead tumors. So some of the tumors disappeared, and then some of them are just completely dead and but just kind of rotting there. So here's another example. This is a patient I recently treated. She had liver metastasis on both the right and left lobes of the liver. You can see here the arrows are outlining there's multifocal tumor here. So again, just like a light bulb, these light up bright white there. And then this is the angiogram. We're going to take a catheter into the right hepatic artery first. So typically I divide the treatments up into a right and left, and we separate that by 1 month. And you can see here, once we select that, you can see all this dense tumor blush that we talked about here. So because of all this tumor blush, we're going to embolize that with the beads that I mentioned. And this is what it looks like again. You can see here, after embolization, all that blush is gone. And we just still have the trunks are there, but the leaves, basically all the blush of the tumor supply is gone. This is 1 month later. Then we bring the patient back. We treat the left side. You can see that we place the catheter now in the left hepatic artery. This is the other side of the liver. And this is what it looks like afterwards. And again, you can see that there's no more flow. The blush is gone. And this is what the patient MRI looked like after a month from there. And this is shows that there's all dead, shrunken tumor. So again, the light bulb has been burnt out. So there's no more tumor that's active here. So this is a really, really nice result. Now I want to focus on percutaneous ablation. Ablation, as I mentioned, is where we take a needle and we directly put it into a tumor. It's a very attractive option because it has really, really good outcomes. It really minimizes the collateral damage. The response rates are actually very similar to surgical resection. So burning or freezing something is almost as equivalent to just actually physically removing it. And so because of this, it actually has a curative potential. So we really like to do percutaneous ablation if we can offer it for patients. And this is an example of what a percutaneous ablation looks like. So you can see here, there's a focal tumor right there that I've highlighted with the red circle. And then we bring the patient, we put them in the CT scanner. And again, we can see the tumor there again. We put a grid on the patient, and then we guide a needle into the tumor. This is a very simplified, I've obviously just shown you in 3 slides what does take some time. It takes about an hour or so, to get that needle in there perfectly. But once the needle's there, we put it in the target. We typically do something called microwave ablation for most of our NET patients, and that's where we're actually burning the tumors away. And that's what that looks like. It's a very small needle. You can see that it goes to the skin. We just put a Band-Aid on the patient's skin when we're done. And then you can see here, again, the light bulb has been burnt out. Look at what was lighting up is no longer lighting up. It's a dark hole there. And so that's a cavity of dead tissue. Now, the limitations of ablation mainly are that because we're putting needles in patients, we can only do this for a few lesions and only when they're small. The ablation needles can only burn a certain size, usually up to 3.5 centimeters or 4 centimeters. So you can only have a few lesions, and they can't be that big. Aside from that, there's a lot of challenges with ablation, and there's some certain challenges that I'm going to talk about that will be sort of the focus of today's talk. Is how can we overcome some of these challenges with ablation? These challenges include that the tumors can be very difficult to visualize. The other thing is that tumors near critical structures like blood vessels or adjacent organs can be damaged if you burn or freeze them. And then, even though it's minimally invasive, still it requires a needle going through the skin, so there's always a risk of bleeding or infection. So I'm going to focus on these 3 things and what the improvements lately that we've sort of been developing, in our field to sort of overcome these. So we've developed methods to improve the visualization of these difficult to see tumors. We have ways to now improve safety of ablation of tumors near critical structures. And then there's also potential future advances that we're really excited about, where we can actually do ablation without actually puncturing the skin at all. It's a completely non-invasive way to do ablation. So methods to improve visualization, as I mentioned, small tumors can be very difficult to visualize, but these are the tumors that are actually ideal for ablation because they're small. So unfortunately, though, if you can't see a tumor, you can't place a needle accurately within it to treat it. So it's a little bit of a tricky situation. So we now have some advances that we're using in imaging to help improve visualization. There's many different advances actually, but one of the ways that I'm going to talk about is something called angio-CT, where we actually take a CT scanner and we combine it with a traditional X-ray suite. And what that allows is using X-ray, just like we were doing those intra-arterial procedures, we can actually take a catheter into the arteries of the liver with the live X-ray, and then we can inject dye to light the tumor up. Then, just like we were doing our ablations before, under the CT scanner, we can actually visualize the tumor very easily and then place the needle accurately. So here's an example. This is a very small tumor that was metastatic to the liver. You can see here, you can barely see it. The arrow really helps here to kind of help visualize it. And then we bring this patient for ablation, and normally we can't give dye to a patient during an ablation because the dye will just wash away. So it's very difficult to see, again, barely imperceptible. So this would potentially be at risk for an incomplete ablation. So we catheterize the artery that feeds the tumor there, and we inject the dye to visualize it. Because we can do this all in the same room, we can actually now put the patient in the CT scanner again, and you can see the tumor is very easily seen. You don't need the arrow anymore to sort of visualize it. So again, now we can position the needle into the tumor with the dye to visualize it, and we can burn it away. And you can see here now we have a dead sort of cavity. And here's the initial CT afterwards that showed no active tumor. So now I sort of almost routinely do this for most of my ablations for my patients. What about tumors that are near critical structures? So as I talked about, most ablation that we're doing for cancer is thermal. We're either burning it, we're freezing it. And as I mentioned for NET, we're primarily burning tumors using a technology called microwave. And microwave is very effective, but it has a potential to burn or damage critical structures like bile ducts, gallbladder, nerves, intestines. So there's a lot of critical things in the liver that we don't want to burn. Now we have some newer technologies that are non-thermal, so they don't utilize heat or freezing energy, and that really sort of reduces or lessens the risk of damage of these critical structures. And one of the main technologies that we're starting to use is something called irreversible electroporation, or IRE. And with IRE, we're basically electrocuting the tumor. We're putting needles actually around the tumor more often than actually through them. So we actually just bracket the tumor, and then you sort of surround it, and then you basically apply this high voltage electrical current, and that actually just pokes holes in the membranes of the tumor, and that causes cell death. And the beautiful thing about IRE is that it doesn't impact all tissues equally. It actually has the potential to protect or not disrupt structures with a lot of collagen. And unfortunately, all the things that we want to protect are structures that have collagen, like the blood vessels and the bile ducts, and as well as the blood vessels. So here's an example. This is a patient who actually had a tumor in the pelvis that we're asked to ablate, and you can see it's close to the rectum, and there's a lot of nerves in the area. And so we proceeded with IRE, and you can see what we did was we actually bracketed it like a triangle. And you can see here the tumor, as I've shown here with the red circle, actually is in between the triangle. So we've bracketed the tumor with the IRE needles. This is what it looks like. And again, it's very minimally invasive. The needles are just around. We just put a Band-Aid at the end. And again, this is a very short ablation cycle. And then you can see here there's some gas in the area. That's the black area that shows that the tumor has been essentially electrocuted. So finally, can we make ablation even safer? So no matter what the current technology we use for ablation, it still requires placement of one or more needles through the skin. And there's a new technology that we're actually fortunate to be working with called histotripsy that actually may eliminate the process and make the procedure for ablation completely non-invasive. And the way histotripsy works is it actually uses ultrasound energy. And ultrasound, we typically know ultrasound as a diagnostic tool. We can look at structures in the body with an ultrasound, but ultrasound actually has the potential to treat patients if you harness the energy to actually create cavitation. It's actually used to be a sort of an unwanted side effect of ultrasound. Used to be cavitation, but actually harnessing that energy, you can actually create a beam of this, and you can cause basically like bubbles that lead to cavitation and tumor destruction. And again, similarly to IRE, it actually has the ability to preserve critical structures that may be nearby. And the best part is that it doesn't utilize any radiation. So it's a completely non-invasive and no radiation. This is what it actually looks like. This is like a specimen that's been treated by histotripsy. So it's like an asteroid hit this tumor, and you created this actual cavity of space. And the first in-human studies were completed in Europe, and the first trial in the US just started over a year ago. There's only 10 sites, and we're fortunate to be one of them. We recently, a few months ago, treated our first patient. This is what it looks like. So it's not even a sterile procedure because there's nothing going in the body. You can see we place a water bath over the patient, and then it's a robot. And you can see here, that's the bubble cloud there in action there. The ultrasound, you can see the red is where we are harnessing the energy. And that's a picture of me on the right there, basically just watching the procedure after we position the ultrasound into the area of interest. So in conclusion, interventional therapies are non-surgical treatments that directly target tumor to minimize the collateral damage. As I mentioned, there's both intraarterial, which we use for patients who have usually a lot of tumor, as well as percutaneous, which is usually for patients who have a small amount of tumor. And then, as I mentioned, percutaneous methods include various types of ablation to directly place needles into the tumor to destroy them. And recent advancements have helped us improve visualization as well as protect critical structures, and then also potentially allow us to do these procedures completely non invasively. I thank you for your time and your attention, and I welcome any questions. Feel free to email me or contact me on Twitter at any point. Thank you.